Hello, welcome to today's Insta Live, and today we're talking about the female fertility assessment. For those of you who don't know me, my name is Andrea Trigo. I am a nurse consultant, the founder of Enhanced Fertility, but I am also a patient, and my diagnosis and assessment of my problem took many years, over 3 years. So today I want to talk about female fertility assessment. And we want to talk about the different ways that women can be assessed. And to join me, I will have Dr. Leticia from Referral Clinic. She's going to join us and talk to us a bit about the incidence of female problems that can affect female fertility. How can these be assessed? And how can treatment be targeted to these different types of problems that we can find? And the reason why we wanted to talk about this topic is because the International Women's Day around the corner. It's next week. So we want to celebrate women and we want to help raise awareness of female fertility problems as well. So I'm inviting Dr. Leticia to join us. And of course, we'll drop this video as well on IGTV. And if you want to watch us later, you can do so as well. Hello, Dr. Leticia.
Hi, how are you?
I'm okay. How are you?
I'm fine, thank you. I just need a little bit of light. Wait. I think, yeah. It's okay, right?
It's good. It's perfect. Thank you so much for joining us today.
No, thank you for inviting me.
I was just saying that it's going to be International Women's Day next week. So we wanted to talk a bit about female fertility and to help raise awareness around that as well. So thank you for joining us today.
Thank you. Yeah, it's a really interesting topic because a lot of women doesn't know about they have this problem, and it comes an age that they cannot do anything. So I think that as more as we can talk about this, it's better for them. That a lot of girls come into our office and they don't even know they have a problem. And we are, as a gynecologist, we don't even do the proofs. Some laboratories or what we could do, because they are not in the articles that we should do it in younger women, but I think we should do it. So, I mean.
Yeah, we do see a lot of young women in their early 20s, and they may have some symptoms, and usually they are prescribed the pill, which of course masks some of those symptoms, so they don't even know that they might have a problem later on getting pregnant. What is the incidence of female fertility problems in the general population?
Yeah, well, in the couple, the woman takes like 3% of the problem, and the male, the other 3%. It's 20% for unknown causes and another 20% of mixed causes. But in the women, it's about 40% ovulatory causes,
So it affects a lot of people. A lot of women are being affected by this problem.
Yeah, and the worst thing, I think the worst thing is that they don't even know it, because we are so focused on our professional life, in our professional growth. So it's a little bit difficult for us to knowledge it. It's weird.
Yeah, and lots of people think that having painful periods, for example, is normal. So there's this idea that maybe this is part of the process, and maybe I don't need to investigate it, and they don't investigate, and then it might be a problem.
Yeah, what you're saying is it's really true, because endometriosis is one of the causes. It takes, I think it's 15% of the causes of infertility, of one infertility, and the girls don't even know it, because, as you say, they are used to get a lot of dysmenorrhea, or this pain every time their period comes, And yeah, they are used to have these pains, and they don't go to the doctor to look for some, help. So when we diagnose it, it's a little bit late. When we have like a lot of problems, we already have a low ovarian reserve, and for example, the tubes are already obstructive. So it's,
So
yeah, you're totally right. Yeah.
you've touched on endometriosis, and what other possible causes or problems could cause female infertility apart from endometriosis?
The first cause, as you put it on your Instagram, I saw it yesterday, like you were like doing a questionnaire. It's, as you said, the hormone ones. The ovulatory causes are the first ones because, for example, the polycystic ovarian syndrome is one of the causes, and people, the girls don't realize they don't have their period like every 41 or 35 days, They have to know that if it doesn't come like every 21 or 35 days, it's not okay. So you have to go to the doctor, for help so that you can have a visit with them. Also, the first thing that they do is like take the contraceptives, because for them it's normal. Like, yeah, if I don't have a regular cycle, I'm going to the pharmacy and take some contraceptives to make it regular. And this is not should be taken like that, like so normal.
Mm-hmm.
What else? The other reason for infertility, besides ovulatory and endometriosis, is, for example, malformations that they don't even know, or some obstructive tubes, for example, or infections could be too. Like a lot of women have pelvic infections, and they don't go to the doctor. They just go to the pharmacy and get some pills or whatever. And after some time, they already had a lot of damage because of that. Like so.
So we have,
Yeah, those are the most common causes for anovulatory and infertility disease.
yeah, so you have all those hormones playing a part. You mentioned some obstructions as well. I'm imagining maybe some fibroids or septums, things like that, that could affect implantation. And
Yeah, for example, polyps and myomas and adenomyosis, those kind of things affects a lot the implantation of the embryo.
yeah.
So, for example, one of the proofs that we do, it's not like a common one, but one of the things we do after the basic ones, it's like the hysteroscopy, for example, because we can see if there's a cervical stenosis, or if there's a polyp, or if there's a myoma inside the uterus. So, yeah.
And I'm imagining that sometimes there can always be problems as well in the eggs themselves. If there's not enough eggs, or if they are of poor quality, maybe that can be a cause as well of fertility problems in women.
Yeah, one of the causes that I forgot to say, thank you, it's the low ovarian reserve. Yeah. And it's the second reason of infertility. As I said, that a lot of women doesn't want to have kids right now because they are like thinking about something else, like our professional growth, for example. So they don't look for help earlier. And, we have this quantity of eggs, of follicles when we are born. And every cycle, there are some lost of them. But in this low ovarian reserve, what we have seen is that there's a decrease, in this quantity of eggs. So when you have maybe 35 years old and you want to have some kids, there are women that their ovaries have 41 years, for example, So what we can do here, what we do is to examine the low ovarian reserve. We do this hormone that it's called anti-Mullerian hormone, and it depends on the age, the quantity of hormone. But when we see a hormone below than 2, lower than 2, then we can offer the patient like freeze their eggs, so that they can preserve their fertility. But it's better to do it before 35 years old, because if not, the quality is not the best. The quality starts decreasing after 35 years old. The thing is that they don't know it, so it's difficult for them when they realize it, because they are like older than 35 years old. And even though they can freeze their eggs, it's not the best quality.
Yeah.
So after that, when they try to do an embryo or a FIV, there are a lot of lost, the miscarriage because of that, the quality of the eggs.
And so you've already touched a bit on the AMH test, but what other things can be checked when a woman has been trying to conceive for at least a year? What's part of that basic assessment?
Well, the basic assessment is the hormones, the LH, the follicle stimulate hormone, the LH, the TSH, because sometimes we can have some thyroid problems.
Mm-hmm.
Also, we take progesterone, because we like to know if we have a good luteal phase.
Yeah.
The progesterone and estradiol, So these are the basic hormones that we take. The anti-Mullerian hormone is not the basic one, but I mean, as a fertility clinic, we do take it, because I think we think it's like basic.
It gives a lot of information.
Yeah, it gives you a lot of information, and also, you can prognose how is it going to be in maybe 1 or 2 years. So maybe if you have a patient of 28 years old, because we have seen it, like 21 or 28 years old, and they have an anti-Mullerian of 0.5, so it's like, so it's frightened sometimes for them. It's like, what am I going to do now? So they are like still in time of freeze some eggs, but you have to be really empathic with them, because it's like hard. And well, also other studies that we can do, the basic ones after the blood test, is the echo ultrasound, the transvaginal ultrasound. We can count the follicles, and we can give us a lot of information and idea of how they are every cycle.
Does the scan show already anything like fibroids or myomas, or would that be a more advanced study?
No, that the echography gives us all that information. If there's myomas, adenomyosis, we can see it there. I mean, we see it there, and if we, for example, see like some signal of endometriosis or something like that, then we do more specific studies. Mm-hmm. But this is like the basic ones that you asked me, is the echography, this blood test, and also there's a kit. Yeah, this ovulatory kit test.
Okay.
That I think I also saw it on your Instagram, and it's really good because you can see if you are ovulating,
Okay.
So I think it's really good that you put it on your Instagram too.
And many people are already tracking as well their ovulation, aren't they? And I think the more information they take to that initial appointment, it can help you as well think about what could possibly be causing the fertility problem.
Yeah, exactly. And for example, if we have a doubt or something in the transvaginal echography, then we can do another thing like the hysterosalpingogram with contrast or something. We do more specific studies after that if we have some doubts.
And if everything is okay, or even if you find a problem, I imagine that some women will require more advanced checkups and assessments. What sort of other assessments can women expect along the way?
After the basic ones?
Yes.
Yeah, after the basic ones, then if we have like everything okay, then we have to do like an hysteroscopy, for example, when we can see, directly if everything is okay inside the uterus.
Yeah.
And if we see that everything is fine, then we can go and we can do a laparoscopy surgery, but it's like really more invasive. More of the most of the cases, we can realize the cause with the basics studies.
Mm-hmm.
If we have a good and specific questions to the patient, and we know how to read these studies, so we will have we will have the answer of this problem, fertility, of the infertility problem. It doesn't require like too many studies at least in the most of the times.
Yeah.
But also, for example, if we do like more, just to say like more complex studies, will be, for example, the PGT.
Okay.
The implantational genetic testing. We can do that too with the oocytes or with the embryo.
That
That we can study some genetic
that's a good
problems there.
that's a good point, because we talked about the quality of those eggs being potentially a problem, but there is no way of knowing if they are good or poor quality until we fertilize them in the lab and see if they develop, isn't it?
Exactly. And with this kind of test, we can see if our embryo has some anomalies, or chromosomopathies, aneuploidies, or mono.
Mm-hmm.
So this kind of exams can tell us which one is the best, the healthiest one, and it gives us more chance to get pregnant. Yeah.
And
But not just the embryo, also the oocytes. So
and I'm thinking that, for example, if, like you mentioned, if you think that someone might have endometriosis or PCOS, then you might do more advanced things. So let's think about maybe endometriosis. Would everyone need a laparoscopy to identify endometriosis or confirm it?
the bibliography says that it's the best way to diagnose because you see it.
Yes.
Otherwise, you will just like with the clinic, you can know she has endometriosis with this clinic because they have a lot of pain, for example, and diarrhea and nausea. With these symptoms, you can know they have it. We can also do a blood test with the CA 125.
Mm-hmm.
We can do some semi-diagnose with that, but it's not. We cannot do that like the diagnosis with just that. The bibliography says that it has to be with laparoscopic surgery because you see the implements of the endometriosis. So, and we've done it. When we do all these kind of surgeries, the laparoscopic surgery, what we do is to take the biopsy of these implants of endometriosis, or even we can take them all of them out.
Mm-hmm.
And it depends. Sometimes, the ovaries are stick together because of that. There are a lot of other advances.
Yes.
So sometimes it can. That's why it causes infertility because it's a chronic illness, a chronic disease, and with time, women are not used to ask why they have a lot of pain. They are used to know that it's normal, and it's not normal for us to have pain
Yeah.
during our menses. So laparoscopy surgery is the best way to diagnose endometriosis. Yeah, and to treat it as well. After that, after the surgery, we can do some hormone suppression.
Okay.
Because endometriosis is caused by a lot of estradiol. So if we suppress these kind of hormones, then we will stop endometriosis for keep growing. And after that, we can start doing a fertility process. Yeah.
So it's like the treatment is changing as the cause it depends on the cause, and then you'll target the treatment to that.
Exactly. It depends on the cause. Yeah, exactly. Depending on the cause, the treatment. For example, if we have this polycystic ovarian syndrome,
Mm-hmm.
we can we give some treatment with clomiphene, for example, so we can cause an ovulatory cycle.
Yeah.
Because the problem with this is that we have a lot of estradiol, and we cannot do this ovulate. The cycle doesn't ovulate. We don't ovulate because we have like these hormones to the ceiling. So.
And I mean, you mentioned a while back, and I think it was really interesting that you said that when you ask patients lots of questions, you don't need many tests. And that is so true in medicine. If you do a very thorough clinical history taking, then a couple of tests just to confirm your suspicions of what might be happening. And
Yeah, because sorry, yeah.
yeah, I'm thinking about the PCOS case that you were talking about, because with PCOS, women are presenting already with a very distinctive clinical history, isn't it? That may point you towards the direction of PCOS, but then probably the assessment may need to include those other hormones, the male hormones as well, isn't it?
Yeah, for example, if we have a patient that has a non-regular cycle, the first thing you have to search is if she doesn't have the polycystic ovarian syndrome, because it's the most common cause of this irregular cycle of an ovulatory cycle. So if you know it, you search for it. If you don't know it, you don't search for it. So we kind of do some questions to our patient, like for example, do you have some hair here? Do you have hair in your back? Some questions that can lead you to some hirsutism, for example.
Yes.
Or if they are like a little bit with a little bit of weight, obesity or something like that, then you can know if they are like, in most of the times it is, because it's the first cause of anovulatory. And after that, we do the basic studies, that is what as I said, plus testosterone, for example, because sometimes, in most of the times, it's a little bit higher than the normal population, normal women. And after that, yeah, we do the treatment. For example, if in this case, they want to get pregnant, we can give some clomiphene, for example, to make them ovulate. It's an example.
And you mentioned one of the causes that were more anatomical, like the myomas, the fibroids. You mentioned that you could insert a camera and to visually see if they're there. And does the treatment mean that these always need to be removed before going ahead, or how does it work?
No, it doesn't have to be removed all the time. It depends on the size of the myoma. It depends on the size and where is it. Because sometimes, for example, if we have a myoma exactly where it is in the fundus of the uterus, when it's all, because the embryo, where it's in the implantation, the implantation place is the fundus of the uterus. So if we have a myoma there, we probably will have to take it out sometimes. It depends. And it depends on the size, But if it's not there, you just don't touch it. Okay? For example.
Yes, tell me your example.
Yeah, for example, if we have an ovarian cystic, for example, if it's more than 2 centimeters, for example, then yeah, maybe we can do some more than 5 centimeters. Sorry, yeah, maybe we can touch it, but if not, it's better to just leave it there, because if not, we can have more consequences in this ovary.
Yes. And so the idea that a lot of people have, that if they can't get pregnant naturally, they will need to have IVF. That's not always the case. Maybe it depends on what the problem is, isn't it?
Yeah, it depends on the cause. Also, we have to know, and yeah, it should be said that in the normal population, in the normal percentage of getting pregnant in 1 month is 25%, you know,
Yeah.
and in 3 months it will be 60%, and in 1 year it will be 80%, and in 1 year and a half, 90%. So it's it's normal if in the first months we don't get pregnant. It's normal, and it should not be a reason to be scared and to go running to the doctor. I mean, not a lot of women know this, and it's normal. But yeah, the first year, if you don't get pregnant the first year with less than 35 years old, so we can still wait. But after one, I mean, if there's a regular cycle, if everything is okay, if you have a regular cycle, then it's probably normal to not get pregnant the first 1, 2, or 3 months, because of this. It's normal. These percentages are normal. But if you are older than 35 years old, then you have to, if you have like regularly cycles, after 6 months, and after 6 months you don't get pregnant, then yeah, you have to look for help. Yes.
And Dr. Leticia, if I usually say that women are as unique as their cycles, and they need to get to know what is normal to them. And if there's anyone listening who has been trying to conceive and they notice that something might not be quite right, what would be your advice to them?
To go to a doctor. Don't be shy. Go to a doctor. Any questions are valuable. There's no dull questions or stupid questions, because there's a lot of women that don't go to the doctor because they're shy or they don't want to. Just come with us and we will help you, because it's normal to have doubts. No one knows anything. And don't look for Dr. Google. No, that's the worst thing you can do,
Yeah.
because a lot of people just, it's like, oh yeah, let's Google it. But no, Google is not a doctor.
Yeah, there's so much false information out there, isn't it?
There's a lot of false information, and a lot of girls just read it and they don't come to the doctor. So that creates false expectations sometimes, false ideas, or false diagnoses. That's one of the reasons I was saying about these contraceptives, for example, because there's a lot of girls that, because they don't have a regular cycle, they go to the pharmacy and they just buy them and start, use them for years. And this is not right for them. So if you guys are listening, or if you see this, watch it, actually, just look for us and ask any questions. There are not full questions, everything it's important for us, so you can know what is normal and what is not normal.
Thank you, Dr. Leticia. It was great talking to you and sharing awareness of female fertility ahead of International Women's Day. Thank you so much for clarifying all our questions.
Thank you, Andrea. It really was nice to meet you.
Thank you. And for
Hope we can see each other again.
everyone who joined later, this video will be left on IGTV, so you can still catch up the beginning. It's definitely worth it. Thank you.
See you. Bye.